Hi, my name is Rachel Smith-Steinert, and myself and Mary Bacus will be covering the discussion for Module 2, which is covering Hamlin's Chapter 5, which is going to cover a number of topics such as managed care, healthcare financial management, and reimbursement. Some other topics that will also be discussed are the uninsured and access to healthcare in the United States, funding strategies for nurse-managed health centers and community-based services, and the concept of pay for performance. So the first topic that was covered in the chapter is managed care. Hamlin goes on to describe that managed care is a generic term that can be defined as a system of healthcare that combines delivery and payment and influences utilization of services by employing management techniques to promote the delivery of care. During the 1980s, the predominant model of managed care was the HMO, which is a health maintenance organization, and the PPO, which stands for the Preferred Provider Organization. Over time, managed care organizations flourished, and lines between the two actually began to blur. An HMO, by definition, is an entity that provides, offers, or arranges for coverage of designated services needed by members for a contracted prepaid premium. A PPO is a healthcare system that typically involves contractual arrangements between a network of providers and a payer. And in this plan, the enrollee has the option to seek care out of a network by paying higher out-of-pocket fees for the enrollee. And primary care case management and enhanced primary care case management systems are forms of managed care that are used by many state Medicaid systems. The chapter goes on to use a few case studies to demonstrate some of these examples. Case study number 1 explains how Wisconsin was one of the first states to implement managed care programs in the Medicaid population by receiving a federal waiver in the early 1980s. Each HMO received $65 per individual per month from the state to provide coverage for this enrollee. This became financially difficult for many hospitals, so an HMO system was set up. This included negotiating provider contracts, developing a claims system, marketing and implementing quality improvement programs. And one major obstacle that the case study goes over is that to increase the use of primary care and to decrease the reliance on emergency services was quite hard for Wisconsin, which I'm sure we have all seen in our hospital experience as well. Case study number 2 discussed the idea of a PPO and PPO development. And it explained the process of information gathering of hospitals prior to contract negotiations with care providers and hospitals. Utilization management initiatives must be developed, and the process involved improvement activities must be reviewed. And this case study explained how a PPO can be derived. Case study number 3 under managed care was the idea of a PCCM, which is primary care case management, and it was used in Medicaid systems in Utah and in Michigan in 1982 and 1983, and the Medicaid enrollees were actually linked with a primary care provider who acted as a gatekeeper of services or as a case manager. And North Carolina actually took this system a step further in 1998 using local case management and actually employed some disease management systems to improve health delivery in the state. Then Hamlin goes on to talk about the uninsured and access to health care. So in 2006, Hamlin quotes an estimated 46,995,000 individuals in the United States had no health insurance. And this is equivalent to approximately 16% of the U.S. population. And this was an actual increase of 5 million since 2001, which was attributed to the erosion of the employer-sponsored health insurance that historically many individuals have taken advantage of. 70% of the uninsured were in families where at least one person was working full-time, and an additional 11% were in families where an individual was working part-time. 24% of the uninsured made less than 25% annually, which was significant because that meant that they didn't qualify for any state or public assistance, but they actually could not afford to pay themselves for individual health care. The uninsured are less likely to seek services, which we all know, and receive preventative services and have regular care providers, and are more likely to use emergency care services. In 2005, the uninsured women participated in the National Health Interview Survey and reported the lowest use of mammography screening at 38%. So from these results, the Hamlin text goes into a case study explaining the breast and cervical cancer legislation, which operates in all 50 states in the United States. And from that legislation came the Breast and Cervical Cancer Mortality Prevention Act of 1990. And what this act states is that women who are underserved or uninsured may qualify for free or low-cost breast and cervical screening through the CDC. And the chapter actually goes to explain a case study where an individual without health insurance coverage who has found a lump in her breast actually delays seeking care because she does not have health insurance and is unaware of the Breast and Cervical Cancer Mortality Prevention Act. But she finally goes and has some screening work done and is recommended for a mammography. And the mammogram shows that the lump is there and it is biopsied and is positive for malignant cells. So she has a mastectomy, but then begins to receive bills from the hospital that she cannot afford. And even though the hospital explained to her that part of her bills would be written off due to her lack of insurance, she starts to receive bills that she cannot afford, so she no longer seeks further treatment that she was recommended to do, which was chemotherapy and radiation. And so the case study just illustrates the point that the uninsured seek care later for illnesses, and that often their care is very fragmented and that it is incomplete due to a lack of health insurance. Hamlin then, after discussing the uninsured, goes on to the topic of funding strategies for nurse-managed health centers and community-based services. And nurse-managed clinics and health centers are managed and staffed by registered nurses and nurse practitioners. And often these centers serve vulnerable and underserved populations. And despite their benefits to the community that have been shown by numerous studies, these models of care often face many barriers with respect to funding and traditional reimbursement. So fee-for-service Medicaid programs are required now to cover services provided by some advanced practice nurses, specifically pediatric nurse practitioners, family nurse practitioners, and certified nurse midwives. Within Medicaid managed care systems, states have the option to include or exclude nurse practitioners. So the covered services actually vary from state to state. In 1997, Congress authorized nurse practitioners to be directly reimbursed for care covered by Medicare. And so the chapter actually goes on to include 3 case studies that illustrate this point. And the first case study talks about Edmark Hospice for Children, which cares for children and their families in the comfort of their own home. And in 2008, only 10% of the annual operating budget for this hospice organization came from third-party reimbursement services, and 90% of the operational costs were actually covered by charitable donations. And a number of states are now currently working on funding for children with life-threatening diseases, because often pediatric children that have life-threatening diseases do not cover or do not qualify for traditional hospice under traditional definitions. The next case study talks about Englehart Medical Center, which is located in rural North Carolina, and this health center actually cares for 5,000 individuals that live in the Englehart, North Carolina district. The closest medical system for these individuals is over 50 miles away, and a nurse practitioner provides the primary care, and one private insurance company specifically will not certify the nurse practitioner as a healthcare provider because she is not a physician. And so this has dramatic reimbursement implications for this medical center that really serves an entire population. The next case study under funding strategies for nurse-managed health centers is talks about the cardiology specialists of the Carolinas. And it's a mixed physician and nurse practitioner group, and the team emphasizes primary, secondary, and tertiary cardiac care. And all the providers, the two physicians and the nurse practitioner, see new patients and have expertise in specific cardiac areas. But the nurse practitioner is only reimbursed at 85% of what the physicians are reimbursed by Medicare Part B. And this dramatically affects the reimbursement and recoupment for this cardiology group. And the implications of this are also discussed in the chapter. The next topic in Chapter 5 in the Hamlin text is the cost analysis of healthcare programs and services. So in the United States, the combination of high levels of healthcare expenditures and relative failure to improve the health system of the population shows the need to refocus the healthcare delivery system. So as the complexity of the system continues to increase, the benefits have failed to keep up. In fact, the health status of the U.S. lags far behind many other developed countries in the world that spend significantly less on healthcare delivery. So advanced practice nurses have the skills to evaluate the outcomes and costs of services to help set new priorities, better utilize scarce resources, and create a more cost-effective system. The text discusses 3 cost analysis approaches, which are cost-benefit, cost-effectiveness, and cost-utility. And all 3 types estimate the cost in the same way, but differ on how they approached and how they measure consequences. And then the next topic that Hamlin discusses briefly is pay for performance, which we are currently all hearing a lot about in our workplace environments. And in the past, historically, fee-for-service reimbursement was the principle of paying healthcare providers in the U.S. And because it was often associated with higher levels of utilization, inefficiency, and not necessarily higher quality care, agencies such as Medicare, Medicaid, and private insurance companies are changing the way that they're reimbursing providers. So in 1983, Medicare changed to a prospective payment system using diagnosis-related groups, or DRGs as they're known, and to using per diem, per case, capitated, salaried, or other payment arrangements. More recently, they've begun to deny payment to hospitals for preventable errors such as leaving surgical objects in patients, air embolisms, blood incompatibility, serious bed sores, injuries from falls, UTIs from catheters, and vascular line infections. They have also started paying for performance initiatives. So hospitals that score in the top 10% for a set of quality measures related to acute MIs or coronary artery bypass surgery, heart failure, community-acquired pneumonia, and hip and knee replacements will receive actually 102% of the standard DRG payment to incentivize high-quality care. So many commercial healthcare plans, as well as Medicaid, have followed Medicare's lead using pay-for-performance initiatives. And the program incentives include bonuses for achieving predetermined thresholds and tiered bonuses based on comparative rankings with other providers. So some discussion topics that we came up with and that are listed in the Hamlin text are number 1, identify a type of managed care structure that you would rather participate in as a contracted provider and give reasons why this is the preferred system of care. Number 2, what federal and or state policy changes do you think need to be made to increase access to health care for the uninsured? Number 3, who do you think should fund nurse-managed services, and what type of reimbursement structure might support these services? Number 4, select a healthcare topic of interest, perform a cost analysis, and compare a treatment-focused approach with approach that involves primary prevention. Or number 5, what do you think are the pros and cons for pay-for-performance? So there's a number of topics that are listed in the Hamlin text for Module 2, and we look forward to a lively discussion. Thank you.